Dialogue with a Doctor, featuring Southwest Florida's leading physicians.
Hello and welcome to Dialogue with a Doctor. This is a show where we interview experts in the field of medicine, whether that be surgical experts, which we have here today, or medical experts. And we ask them about their craft and to educate us about what they do to inform you so you know what to do when you're faced with some of the situations we're all faced with in medicine during our lifetime. This evening, actually it's daytime, we have Dr. Eichten today. Dr. Eichten is a board-certified orthopedic specialist and specializes in knee replacements, hip replacements, and also, just as importantly, and perhaps more importantly, non-surgical interventions in the knee, biologics, etc. And we're going to be talking about that. But first I want to ask Dr. Eichten about himself, where he comes from, how he ended up here, what his training is.
Well, thank you very much for having me again. It's a pleasure to be back. I did grow up in Minnesota, nice cold weather, so I decided to come down here. Actually, my medical school sent students down here, and that's how I got familiar with the area. After I finished my orthopedic training at Ohio University in Dayton, Ohio, that's when I decided to come back. I did an extra year fellowship in just focusing on hip and knee replacement. That's called a fellowship. So we did hundreds of joints during that year, and that's where you kind of, perfect your skills. And when you do that, the patients have better outcomes. You have a better career because your patients are happier, and that was very beneficial. And this is my 5th year in practice now. Time's really flying by. But there's a lot of new things, a lot of exciting things, especially in the area of joint replacement. The populations are getting older, the numbers are getting more and more patients have arthritis and are in need of some treatment for their knees or their hips or other joints.
Can you tell us a little bit about your practice, where you're located, and what type of physicians you have?
I joined Joint Implant Surgeons of Florida. We have 2 locations now. One is on College Parkway in Fort Myers. The other one is on Immokalee Road, close to 41 in North Naples. That's been open for about 2 years now. So we cover the whole, Southwest Florida area. And I do have privileges at Physicians Regional and Naples Community Hospital, as well as Gulf Coast Hospital in Fort Myers.
How many physicians do you have in your practice?
Yeah, the concept of our practice is to kind of have everything in one place. Currently we have 7 physicians. We just added a pain management physician. We have 2 joint surgeons. We have 2 hand surgeons. We have a sports medicine surgeon. So we kind of cover everything from head to toe.
That definitely is just about from head to toe. So many of my patients will ask about when they should have a joint replacement because they put it off. They don't know how long they should put it off. Some people have less pain than others, and they don't want to just rush down and get a joint replaced. On the other hand, they don't want to wait too late to where there's some structural issue that makes it problematic. Correct. So could you talk about that a little bit?
I think as far as the timing of joint replacement, most patients will have done the non-operative treatment, physical therapy, anti-inflammatories, and there's a multitude of injections that we can do now. If your alignment's pretty good and we can control your pain with some of the non-operative stuff, you don't need to have a joint replacement. If you start to have a deformity, and patients can get very bow-legged, or they can get knock-kneed where their legs are turning out. The greater the deformity, the harder it is to fix, and the longer recovery that you're going to have. So it's hard to tell somebody, you have to have a knee replacement if they're not having knee pain and they're getting by and doing the stuff they like to do. When you don't do the surgery, you don't have any complications from surgery or anesthesia. So we try to keep you going as long as possible. That also, you worry about, the implants wearing out. Right now, the technology for the polyethylenes and everything's lasting a long, long time. But the longer you wait, the less time that the implant has to last. So there's benefits and downsides to waiting or doing it sooner. So if you have a severe deformity, I would say get it done sooner than later. You're going to recover quicker. It's easier to realign the limb.
So how would somebody have a deformity but not have pain?
Most patients can control their pain with anti-inflammatories or injections, and you can do that as long as you want to. I do have some patients that, for whatever medical reason, their heart doctor or lung doctor doesn't want them to have surgery. We can control the symptoms. The knee's not perfect, but you can live with a severely arthritic joint. You're just not going to be very mobile. So we try to get it done before that gets to that point.
So some people will choose, their lifestyle will kind of dictate.
Or they stop doing what they used to like to do, or they stop playing tennis, they stop playing golf. And if you decrease your activity, you're not going to have as much pain. And arthritis pain kind of comes and goes.
So when is it too early to replace a joint?
If there's still cartilage left, there may be some way to preserve the joint. And we've done a lot over the last year as far as a new regenerative medicine. We're trying to regrow cartilage. So I think some of those applications can be used and can be beneficial. Right now we're trying to figure out which patients it works the best on. If you already have a deformity, I don't know that it's worth spending the money to do the stem cells or the biologic therapy. We do a lot of the lipogems, which we take the stem cells from your own tissue, it's from your fat tissue, and we transfer it to the knee, and we're trying to get the cartilage to regrow. That has happened in some of our patients, and I'd say maybe 10% of the patients didn't get a good response. So there's plenty of things that you can try before doing the knee replacement.
So you mentioned lipogems, but what are, other than, patients are familiar with steroid injections, anti-inflammatory cortisone injections in the knee. What other options do they have?
So some of the non-operative treatments would be therapy. You can strengthen the muscles around the joint. That helps with the pain. The cortisone is an anti-inflammatory, but it doesn't change the biology of the joint. The other one would be amniotic tissue. So it's from donated tissue. It's got a lot of growth factors in there, and it can help with inflammation in the knee. There's also platelet-rich plasma, or PRP, and that's your own blood. You spin it down, and then you inject it into the knee, and that can kind of slow the progression of the arthritis.
And then you talked about, so are you doing some amniotic injections or PRP injections?
Yeah, I do some of that too.
So
we offer everything at our practice, and we kind of go through it with each patient, what's the best choice for them. I don't want to say that the stem cells work on everybody. Some patients it doesn't. So I'm very honest with my patients, and we try to find the correct treatment plan for them to keep them comfortable. If that doesn't work, or they have a bad deformity and none of the non-operative stuff's working, then we replace their joint.
The pressure is on to move toward biologics and not operate unless absolutely needed. So how would you compare amniotic PRP and how are they used differently?
They're all injections into the joint. It's different. The PRP has your own growth factors in there. The amniotic tissue has growth factors also, but you can't really quantify the amount of stem cells that are in there. So the stem cells, and that actual cell is the one you want to change into a cartilage cell. So once it gets into the joint, it has a possibility. I don't think the amniotic tissue or the PRP can change into cartilage cells. So the ones that we've seen regrow the cartilage would be the stem cells. The stem cells have active, they secrete proteins, RNA, all this biologic cytokines, stuff that stimulates your body to heal itself. The main problem with cartilage is there's no blood supply to the joint cartilage. So when it wears out, it's gone. So it's basically like your tire tread. Once the tread's gone, you don't try to throw some new tread on there, you buy new tires. So if we can get your body to regrow the cartilage, The reason it doesn't send in new stem cells is because there's no blood supply going to that cartilage. And that's why we see so much arthritis.
So the amniotic and the PRP, that concept's been around for a while. But, you know, growing cartilage with stem cells is talked about but not been as practical until more recently.
Yeah, I think using the fat tissue, and they've been doing this in other countries in Europe, the fat tissue has more concentrated stem cells, you know, 100 to 500 times more stem cells per volume than if you take it from the bone marrow. So we're hoping with the increased amount of stem cells that they're going to be more active and can regrow the cartilage better. So again, this is very new technology. It's in the early stages. With time, we're going to get more and more studies that can show, you know, right now we have animal studies, we have some case studies that have before and after x-rays where the cartilage regrew, or we have arthroscopy pictures before and after. So we know that there's an application for it and that it works. We're just trying to figure out how effective is it, how many patients is it going to work in, you know, and then it becomes a cost thing too. You know, it's a lot cheaper than doing a knee or hip replacement, but insurance is not going to pay for it unless it's in a, you know, efficacious treatment. So right now they'll pay for cortisone, and there's also Synvisc or some of those Hyaluronic injections that we also do. Insurance will pay for those, but they won't pay for any of the newer stuff.
So it's not to say it's not efficacious, they just are not on board or with knowing that it's efficacious.
Right,
yet.
And until you have enough studies, you know, but if you're waiting to have your knee replacement and you want to try something, the studies aren't going to be done in time.
Well, if bone marrow, to me, getting bone marrow is an issue. You got to get into the bone and it can hurt, et cetera, whereas just taking it from fat, in this case abdominal fat, it's just much easier and there's more stem cells.
Yeah, it's a very simple procedure and the biology makes sense, and that's kind of why I'm doing it, and it's also FDA approved. Because you're not manipulating you're not changing the tissue, not adding any drugs, the FDA has approved it as a procedure. And we do all these in the office, so it's very simple. You don't have the pain from extracting the bone marrow, that type of deal. So it's been very good.
So what you're talking about is this product here, Lipogems,
Correct.
This particular proprietary product, which originally came out of
Italy.
Somebody invented that.
Yeah, it was actually a plastic surgeon.
A plastic surgeon.
Yes, and he was taking the fat, and he said it was too big to put. He was doing implants in the you know, under the eyes, trying to fill in gaps with the fat, and he wanted a way to make it smaller. So he did that, and patients weren't getting inflamed. They weren't having the usual reactions that they have. Because once you get the fat, you clean it with saline. You get rid of the oil and the blood, and you're just left with the stem cells and a lot of growth factors. So he found, you know, pretty good results with this, and he's like, "What's going on?" He sent it to France. They analyzed it. They said, "You have a ton of stem cells in there. That's why you're not getting the inflammation. You know, you're not getting infections, and patients are having really good results." Since then, they've applied it to, you know, different fields, urology, orthopedic, so it's starting to gain traction, especially in the United States. And they've done, you know, over 8,000 of them worldwide. So it's definitely picking up momentum, you know, and they're doing it at different places across the country, Chicago, New York. So it's just a matter of finding, you know, which patients are going to work for it and then getting insurance on board.
So we're going to take a quick break.
Sure.
And then I'm gonna ask you more about this just so people understand how it's done.
Sure.
And then we'll talk about
the alternative.
When all else fails. Okay, so we'll be back in just a moment after a quick break.
At Joint Implant Surgeons of Florida, Dr. Eichten offers state-of-the-art orthopedic care. Dr. Eichten gives special attention to each patient's condition. He listens closely and offers individualized treatment plans, including physical therapy, injections, regenerative medicine treatments, and surgery. Our patients receive a high level of expertise and service which is unparalleled in any other orthopedic practice. Find out what sets us apart and where your new joints will take you. Take it from one of our patients.
I am grateful to Dr. Eichten for offering me an alternative to surgery for my knee pain. After just 6 weeks of lipogens injections, my pain in my knee has been resolved and I'm back doing what I love to do. Thank you, Dr. Eichten.
Welcome back to Dialogue with the Doctor. My name is Dr. Gregory Leach. We just took a short break and we're back with Dr. Eichten, who's a board-certified orthopedic joint surgeon. Did his fellowship in joint replacement, hip and knees, and so he knows a lot about them. And we've been talking about non-surgical intervention to start. We wanted to talk more, at least before we get to the 3D stuff over here, about lipogems and how it's actually done, because people don't know how that's done.
So the lipogems is a procedure that we do in the office. It takes about an hour. And basically we're taking the fat tissue. You take a small amount, usually from the abdominal area or the flank. And once you have the fat, the filter system is what lipogems developed. And it runs through 2 filters. You clean the fat. And what you're left with is the purified, stem cells. You have growth factors and everything in there. So you don't need to add anything to it. And then we simply inject that back into the joint that's arthritic or the patient's having pain.
So it's actually liposuction that you use, just this small liposuction needle on the abdominal wall, just like
correct.
any standard liposuction?
Yes, and I call it a mini liposuction. So I don't want to get into the plastic surgery territory.
So
but it's a small syringe. That's where you get your suction.
You use a local anesthetic.
Correct.
You suck the fat out of the belly.
Correct.
You can't guarantee any plastic surgery results.
Right.
Then you clean it.
Correct.
And it looks like pure fat when you inject it back into the joint.
Correct.
Okay.
And then it's very sticky material. So when you have defects in the knee and the cartilage, if you look at the end of the joint is covered with a smooth, white layer of cartilage. This red area, the cartilage is worn out. The lipogems actually sticks to the defective areas, and then over time, it takes about 6 months for the cartilage to grow if it's going to grow.
Mm-hmm.
So it's it's more of a biologic process. If you want a quick relief, the cortisone works great and works quickly, but it doesn't change the biology. So we're looking for longer-term results that last longer than a cortisone or any other injections.
So if you have a patient that responds to this and grows cartilage, because I think you've shown me x-rays where you could see where they've grown some cartilage, do you do it again?
We haven't repeated many of them. We're just following the patients and their symptoms.
Okay.
You can do it again. They haven't needed to do that much in Italy, according to the people that I talked to.
Mm-hmm.
So the thought process is that, instead of growing a scar tissue in there, which some of our older procedures did that, which we still do some, we poke holes in the bone marrow, and you can actually get some scar tissue in there.
Mm-hmm.
But it grows more of a scar tissue cartilage, not real cartilage.
Mm.
So the thought is if you can grow real cartilage from a stem cell, it's going to last a long time. It already lasted, depending on the patient's age, 40, 50, 60 years, 70 years in some cases. And, if we can regrow that real cartilage, it's going to have better properties to last longer.
Mm-hmm. Well, that makes sense. I was just thinking more is better, but I guess you just don't really know until you just go down that road.
Correct.
So when all else fails, then you have to do surgery.
Yeah, so if nothing works, patient's in pain, the cartilage is completely worn out, we can replace the cartilage, which is a knee replacement, with metal and plastic. It's actually a polyethylene. And you do that by, you keep as many of the ligaments as you can, but you're replacing just the end of the bone. So this is the metal part. This is the cartilage that came off. So you're replacing the same amount. Usually it's about 7 to 9 millimeters of bone. You're not cutting out the whole knee, you're just replacing the end of it. It's almost a resurfacing. And once you get that resurfaced, it's metal and polyethylene, the knee bends without any bone rubbing, and that gets rid of the pain very consistently.
Mm-hmm. And then the top of the tibial plateau?
The top part of the tibia, you basically take about the same amount, 7 millimeters, just enough to get the metal implant in there, and then the polyethylene locks in there. So you're relying on the patient's ligaments and soft tissue to balance the knee. You're just getting rid of that arthritic cartilage. So when they bend it, it's normal. That's part of the process of the knee replacement. And what you learn, the more you train in it or do a fellowship, is soft tissue balancing. You can make your bone cuts, then you have to realign the limb. If somebody's bow-legged or knock-kneed, you change your releasing of the soft tissue to get that perfect balance.
I see. So how does one prepare for the knee replacement, and what happens after?
So before the knee replacement, we want to make sure that there's no problems with anesthesia or surgery. It is a stress on your body. It's a major surgery. So we try to minimize that. You'll basically see your primary doctor to make sure that you're healthy enough for surgery. If they feel that there's any cardiac issues or heart issues, we'll have you see your cardiologist, sometimes pulmonologist. We want to make sure it's as safe as possible. And basically with the blood work, chest x-ray, EKG, all that's done preoperatively to make sure it's safe. That takes about a week or 2 weeks to get all that done. The hospitals that I go to will have a joint class. It's about an hour class. They kind of go over what to expect when you get to the hospital. That really decreases the patient's anxiety. They know where to go. They know what the rehab facility looks like in the hospital. It's very easy. And then you set up for surgery. After you have the surgery, it's been a big improvement in the last 5 to 10 years in pain control. Part of that is anesthesia doing their nerve blocks. We also can do local blocks around the knee to help with pain. So the pain that somebody had knee replacement 10 years ago, it's a lot different. Recovery is a lot easier. I used to wake up with a lot of pain. Now you wake up pain-free because of the nerve block. And the nerve block, you can do a one-time block for 24 hours, or some patients are going home with a pain pump, and that lasts for 2 to 3 days. So it's been very beneficial. Patients are on less narcotics. So that aspect of the surgery has gotten a lot better. The other major point with the post-operative period, and that kind of has nothing to do with the surgeon, is getting that range of motion. And that's where the therapist is very critical, getting the knee straight, getting it bent. The patient's, the body does not like surgery, so it can be sore for the first couple weeks after, and it's easier to not bend it because it hurts when you bend it. So that's part of the process in the first month to 6 weeks of getting that motion back. Most patients are very good by 6 weeks. By 3 months, they're really good. They've gotten their motion back, they're walking, they realize that arthritic pain that they had is not coming back because the arthritis is gone, and that's a huge benefit at about 3 months.
How long do they stay in the hospital?
So right now it depends on the patient's health, but most patients are going home the next day, so they'll stay overnight in the hospital. I think over the next few years there's going to be a big transition to outpatient joints, which we're already seeing across the country and in this area locally. So that's and we're actually building a surgery center that's going to accommodate that. That'll be up in the next year or so.
Your practice?
Yeah, joint implant surgeons we're building up,
Yeah, that's an amazing improvement for somebody to walk in and walk out with a knee replacement.
Correct.
I mean, that's a big deal.
Yeah, I used to stay a week in the hospital now. Patients are almost doing it outpatient. A lot of it's pain control and the anesthetic blocks. It's minimally invasive now. We don't cut as much tissue as we used to.
I see.
The instruments that we use are a lot smaller, so you cut less of the quad tendon and the patients have less pain. So it's minimally invasive techniques that kind of allow us to, push the envelope as far as discharge and getting patients back to their home environment, which they do better.
And infections, which nobody wants.
Correct, and we do everything we can to prevent them.
Or less.
They're a little bit higher in certain hospital settings. So they tend to keep the joints on a separate floor. So you come in, everything's separate, and then you go home. So
I see. The way to keep it contained. But if it's an outpatient, then you even have less time around.
Less time for infection risk, correct.
That's definitely an advantage. So I think we can talk about, well, I guess partial, or where do you want to go
Yeah,
from
so there's
here?
two different ways to go with knee replacement. Partial knees, a lot of patients ask, am I a candidate for a partial knee? If you break the joint into 3 different compartments, the inside or medial, the outside or lateral, and then you also have the kneecap. A lot of patients will have very bad kneecap arthritis that bugs them going up and down stairs. So with the total knee replacement, you're replacing all 3 of those compartments. So the medial side's taken care of, lateral side's taken care of, and then there's a button, polyethylene button that goes on the back side of the patella. So you're basically getting rid of all the arthritis that's possible in the knee. Now, if you don't have a problem in the lateral compartment or under the kneecap, you can do a partial knee. A partial knee only replaces the inside part of the knee. You can do a lateral partial as well, more commonly as a medial partial, and you're just replacing the parts that are worn out. You're keeping all the other tissue, which is good because you're keeping the ligaments in the middle. The knee feels more like a normal knee. The downside of that is you don't want...
We're going to turn it sideways so
Sure.
we can see the side a little bit.
So, and this is an Oxford knee, and the polyethylene actually moves back and forth. So it's more kinematically like a normal knee. So I like doing partials. You just have to be careful and find the right candidate for it. If you have severe arthritis under the kneecap, you're still going to have pain from that. So you may not want to do the partial. And from the x-rays, we can tell who's a candidate and who's not a candidate for a partial knee.
So how often do you do partials compared to totals?
It's usually about 10 to 20%. I think in this population, we tend to do a little bit more totals than partials. If you go to different areas where there's younger patients, in their 30s or 40s, there's a lot more partials that are done.
And if somebody has a partial, does that preclude them from having a total at a later date, or how does it change things?
If you have a partial, there's still a chance that you may require a total because the other areas can wear out. So if you have inflammatory disease, rheumatoid arthritis, or something that can destroy the other cartilage, you're better off with the total knee replacement. If you don't have any of those, the studies show that at 20 years, about 92% or so are still in. So they have a very good lifespan if you pick the right patient. So you don't want to do a partial and then 2 years later do the total. We know that those patients don't do as good as doing the total right away. So when we discuss surgery and a candidate, I'm thinking what's going to last 20, 30 years. Because the less time you spend in the knee, the less risk there is for various things. And you want the implant to last the longest.
So you were saying, the therapist that does post-operative physical therapy is important. And you have physical therapy on site.
Yeah, in both of our facilities, we have our own staff, our own therapists, and they're in very close communication with us. And they can tell us, if somebody's progressing or if there's an issue. And if there is an issue, they get them right back into our clinic to kind of come up with a game plan. So it's been very helpful to have the therapy on site.
You're hand-picking your therapists and managing them
Correct.
at the same time, right?
Correct.
And you have, I just also want to say, at your practice you have x-ray facilities there. Patients don't need to go somewhere else for an x-ray.
Now you can get everything done in our office. So when we see you for the first appointment, you can get x-rays. And our machine allows us to do standing x-rays. So you're not laying down. That gives us the weight-bearing view of the joint. That's very helpful. So you get your x-rays, you do your medical history and everything, and then you see the physician. We also have surgery scheduling. Everything's kind of in in our office, and it's kind of been set, different stations, so you're moving along the whole time.
Well, medicine is a factory model, even though we don't want to think of patients. We as patients don't want to be in a factory, but it's very efficient. I've been in your office, and it's very efficiently run. I want to thank you for coming to the show.
Thank you for having me.
Teaching us about the knee, and I think next time you come to the show, you'll even know there'll be more that you can teach us. So, thanks a lot for
Thank you very
coming to
much.
the show.